If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. Today we will go through the initial assessment and diagnosis of polycystic ovarian syndrome, focusing on what is relevant in primary care only. For this advice, I have looked at the published advice on the NHS website, North East London Integrated Care Board and Health Improvement Scotland. The links to them are in the episode description. In the next episode, I will go through the primary care management, so stay tuned for that. Right, let's jump into it. Polycystic ovarian syndrome is a common endocrine disorder affecting approximately 6 to 10% of the female population in the UK. It is a heterogeneous condition presenting with a spectrum of clinical features and long-term health implications. The main clinical features are hyperandrogenism, including hirsutism, acne and male pattern hair loss, menstrual irregularity with associated anovulatory infertility, overweight in 40 to 50% of cases, and insulin resistance in 10 to 15% of slim patients and 20 to 40% of obese patients. But all women with polycystic ovarian syndrome are at increased risk of developing type 2 diabetes. What causes polycystic ovarian syndrome? The exact cause is unknown, but it often runs in families. We know that it is related to abnormal hormone levels in the body, including high levels of insulin secondary to insulin resistance, and an increased production and activity of hormones like testosterone. But what is the exact pathophysiology of polycystic ovarian syndrome? Well, it's a complex condition with several interconnected mechanisms. First, there's disruption in the hypothalamic pituitary ovarian axis. The brain increases the frequency of gonadotropin pulses, which leads to more stimulation of LH than FSH. This imbalance, often with a higher LH to FSH ratio, stimulates the ovary's thicker cells to produce excess androgens. These androgens are responsible for many of the clinical features, including hirsutism, acne, and male pattern hair loss. Low FSH also means that the follicles in the ovary don't develop properly. They tend to grow to around 6 to 7 millimeters, but they don't ovulate. These small underdeveloped follicles build up around the edge of the ovaries, creating a classic appearance on ultrasound. To make matters worse, those high androgens levels further disrupt follicle development, reinforcing the cycle of anovulation. And when ovulation doesn't happen, periods become irregular or stop altogether, which increases the risk of endometrial hyperplasia due to unopposed estrogen. Another major part of the pathophysiology is insulin resistance. Many women with polycystic ovarian syndrome, even those who aren't overweight, have insulin resistance. The exact reason isn't fully understood, but it's thought to be connected to a defect in insulin signaling inside muscle and fat cells. This hyperinsulinemia, together with the excess LH, stimulate even more androgen production by the ovaries, and it also lowers the liver's production of sex hormone binding globulin, which raises the amount of free testosterone. And to add to all this, those excess androgens go on to worsen insulin resistance at the tissue level, creating a vicious cycle of more insulin, more androgens, more resistance, and more insulin again. How is polycystic ovarian syndrome diagnosed? It can be diagnosed when 2 out of the 3 following Rotterdam criteria are met. These are oligo or anovulation, clinical or biochemical signs of hyperandrogenism, and polycystic ovarian morphology on ultrasound. But this is always after excluding other causes such as thyroid dysfunction, Cushing syndrome, hyperprolactinemia, latent-set congenital adrenal hyperplasia, and androgen-secreting tumors. There is no consensus on the criteria needed to diagnose polycystic ovarian syndrome in adolescents. This is because diagnosing polycystic ovarian syndrome in adolescents is harder as the diagnostic features used in adults, for example, oligomenorrhea, acne, and ultrasound morphology, can be normal pubertal physiological events that are transient. We should not diagnose it in under 18s unless both clinical hyperandrogenism and irregular cycles persist for 2 or more years post-menarche. Some, like the American Academy of Family Physicians, argue that for this age group, all 3 Rotterdam criteria should be met before the diagnosis is made. As we can see, the clinical features of polycystic ovarian syndrome are varied. So let's have a look at some definitions in the Rotterdam criteria. Firstly, we have oligo or anovulation. Oligomenorrhea is defined as cycles more than 35 days apart, but less than 6 months apart, and amenorrhea as the absence of menstruation for 6 to 12 months after a previously established cyclic pattern. Secondly, we have hyperandrogenism. This could be diagnosed either clinically by the presence of excessive acne, androgenic alopecia, or hirsutism, or chemically by high serum levels of total or free testosterone. And finally, we have polycystic ovarian features on ultrasound. A single ovary showing these features is sufficient for the diagnosis of polycystic ovarian syndrome. However, we need to be aware that ultrasound is not necessary if the first 2 criteria are present. Ultrasound is only necessary if we needed to rule out a tumor or the patient has met only one of the other Rotterdam criteria. This is because polycystic ovary features can be found in as many as 62% of patients with normal ovulation, with prevalence declining with age. A thorough history and examination are essential. We should ask about cycle regularity, acne, hirsutism, and family history. We should also record BMI and blood pressure, given that these patients are at higher risk of cardiometabolic disease. Baseline investigation should include thyroid function tests, prolactin, LH, FSH, and estradiol to exclude other causes of oligo or amenorrhea, total testosterone and sex hormone binding globulin, androstenedione and dihydroepiandrosterone if testosterone is raised, and if clinically suspected, 17-hydroxyprogesterone to rule out congenital adrenal hyperplasia. And finally, we should consider a transvaginal or transabdominal ultrasound to assess ovarian morphology and endometrial thickness. How should we interpret these results? Well, sex hormone binding globulin is usually normal or low in polycystic ovarian syndrome and provides a measurement of the degree of hyperinsulinemia. This is because insulin suppresses the production of sex hormone binding globulin in the liver. So, in polycystic ovarian syndrome, where insulin resistance is common, the sex hormone binding globulin levels are often low or at the lower end of the normal range. As a result, low sex hormone binding globulin can serve as a useful surrogate marker for insulin resistance. Low sex hormone binding globulin means more free active testosterone, which contributes to the symptoms. We also have that LH, estradiol, and free androgen index are usually normal or elevated in polycystic ovarian syndrome. The reason for the high free androgen index is that sex hormone binding globulin is used to estimate it. So, if sex hormone binding globulin is low, then the free androgen index is likely to be high even when total testosterone is normal, suggesting true biochemical hyperandrogenism. LH is often elevated, especially in slim women, due to the increased gonadotropin pulsatility. A raised LH to FSH ratio, usually more than 2:1, is typical but not required for diagnosis. And then estradiol is usually normal or mildly elevated due to continuous estrogen production from the ovaries and peripheral conversion in adipose tissue, despite anovulation. FSH, prolactin, and TSH are usually normal, and these tests are done to rule out other causes of oligoamenorrhea. FSH is usually normal. If elevated, we should consider premature ovarian insufficiency. Equally, prolactin is usually normal, and if elevated, we should consider prolactinoma or drug-induced hyperprolactinemia. TSH is done to exclude hypothyroidism, which can also cause menstrual irregularity. So these are exclusion tests. They are checked to avoid misdiagnosing polycystic ovarian syndrome when another endocrine disorder is responsible. And finally, we have the total testosterone, which is normal or high in polycystic ovarian syndrome. However, if it is significantly elevated, we will need to check dihydroepiandrosterone, androstenedione, and 17-hydroxyprogesterone to rule out congenital adrenal hyperplasia, Cushing's syndrome, and androgen-secreting tumors. The reason for this is that in polycystic ovarian syndrome, total testosterone is often normal to mildly elevated, but significant elevations raise red flags and need further investigations. Dihydroepiandrosterone increases in adrenal disorders. Androstenedione is produced also by the ovary and adrenal glands. And finally, 17-hydroxyprogesterone is elevated in non-classical congenital adrenal hyperplasia. Additionally, we should also consider Cushing's syndrome or androgen-secreting tumors if the clinical picture is severe. For example, when there is rapid virilization, even if the total result of testosterone is not very high. And let's end with some referral recommendations. When should we refer women with polycystic ovarian syndrome to endocrinology? We should consider endocrinology referral if there are severe symptoms, such as signs of virilization or rapidly progressing hirsutism. When testosterone is significantly elevated, defined as greater than 5 nanomoles per liter or more than twice the upper limit of normal, or abnormal levels of dihydroepiandrosterone, androstenedione, or 17-hydroxyprogesterone, which could indicate the possibility of alternative diagnosis. So that is it, a review of the assessment and diagnosis of polycystic ovarian syndrome. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.